From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
Welcome to this episode. Today we're highlighting important clinical research from the American Association of Cardiology's annual flagship meeting. I'm Jennifer Abbasi, Director of JAMA Medical News. My guest today is Dr. Katie Berlacher. Dr. Berlacher is an Associate Professor of Medicine at the University of Pittsburgh Medical Center and this year's ACC Conference Chair. Welcome, Dr. Berlacher.
Hi, Jen. Thanks for having me.
So you're joining me a couple of days after the conference wrapped up. We're going to talk about several studies that were presented there that have the potential to affect patient care. So let's dive in. The first study presents data from a randomized trial of the PCSK9 inhibitor evolocumab. This was a subgroup analysis of the VESALIUS-CV trial, and it was published in JAMA. It looked at whether intensive lipid lowering with evolocumab on top of statins would reduce the risk of first cardiovascular event in high-risk people with diabetes who did not have atherosclerosis. So why was this an important subgroup to look at, and what did we learn?
Yeah, thanks, Jen. This study is actually one of my favorites because I could immediately think of multiple patients in my clinic that it would apply to. And it is following right on the heels of the recent ACC-AHA dyslipidemia guidelines that just came out last month, which we really focus on primary prevention. And so we don't have a lot of data with the PCSK9 inhibitors and the evolocumabs to see how or where or if they really should be used in this patient population. This is a really specific patient population in that it was high-risk patients or high-risk diabetes, right? So that meant that patients had to have diabetes for more than 10 years. They had to have been on insulin or have known microvascular disease, but no known atherosclerotic coronary vascular disease and like obstructive coronary disease or known strokes. It was also a broad trial, right? It went into 33 countries, which I think is really important for us to think about its application as we talk about its results. And it really did show us that there was a decrease in that large composite endpoint with regards to its comparison to placebo. And this study showed where they were able to get most of their patients was to drop their LDL to actually in the mid-40s. Which then raises the question, this study didn't look at that, but it raises the question of how aggressive should we be in high-risk primary prevention patients? And I would argue, it's pretty convincing to say this would be an area that we should be more aggressive, maybe even more aggressive than just the recent guidelines that came out. These are things that I think really should cause everybody to pause for a moment and say, definitely LDLs less than 70s in high-risk patients, but maybe even lower than that, even though it doesn't fit into the guidelines quite yet.
And so what were the outcomes?
Sure. So the primary outcome was the composite endpoint of CV death, acute MI, strokes, and arterial revascularization. And they found in those who were on evolocumab that it was 7.6% compared to placebo, which was 10%, which is a significant decrease. The overall reduction in cardiovascular mortality was also down, as well as all-cause mortality. So those are important endpoints that I think are real clinical take-home messages for both us and our patients to say, yes, I know that you are on a statin, and yes, I know that that might feel like enough, but if we really want to have the most impact, we might need to think about adding medications like evolocumab in this very specific patient population.
So PCSK9 inhibitors are expensive.
Yes.
So how do you balance that with the benefits seen in this study?
This is going to be the hardest thing, I think, when we get to implementation of this study is how do we actually utilize this information in the day-to-day where I'm applying for prior authorization for patients like this. Many times we know that having a coronary artery calcium score that is elevated for a patient population like this can help, but this actually wasn't done in this study. And I think this is going to push a lot of our insurers to say there is a need for us to allow these medications, especially evolocumab, to be used in certain patient populations, such as the high-risk diabetes patients who don't have known disease. And what they showed also importantly is that that reduction was a little delayed. So the reduction that they saw was about a year out, which I think is also important for us to recognize and to be patient with. There is a return on this, but it's not immediate. It's still outstanding effect. And those are things that we should talk about with our patients, but really advocate both nationally and from a state standpoint so that these medications can be covered for our patients.
Okay. The next study I'd like to discuss compared GLP-1 receptor agonists in patients with diabetes and cardiovascular disease.
Yes.
The question in this post hoc analysis of the SURPASS CVOT randomized trial was whether tirzepatide, which is a dual agonist, was associated with reduced cardiorenal events compared with dulaglutide, which is an older GLP-1 drug. The primary analysis had already shown that tirzepatide was non-inferior to dulaglutide for cardiovascular death, MI, and stroke. This new analysis, which was published in JAMA Cardiology, expanded the outcomes to all-cause mortality, MI, stroke, coronary revascularization, hospitalization for heart failure, and a composite of adverse kidney outcomes. So how does this analysis add to what we know?
This adds in a variety of different ways, right? We actually saw that this too is non-inferior with that larger composite to include renal outcomes, right? So we now have cardiorenal to get to. But I actually think this is really interesting from an exploratory and a mechanistic standpoint, that we are thinking that all of this is really interrelated, both our cardiac health, our metabolic health, and our kidney health, and that to be measuring them separately in these silos is actually probably going to miss a handful of things. And thinking about that largely is advantageous to us and to our patients. And really, the thing that I like to think about is the mechanism of tirzepatide, which is both GLP-1 agonist and the GIP, recognizing that it's not going to be an easy way to get these outcomes, right? We're most of the time going to have a few different mechanisms to get the best outcome for our patients. And this is the complexity of the disease.
Interesting. Okay. And so do you think tirzepatide should be the drug of choice in this cohort?
Yeah, it's hard to say. It was a non-inferiority trial, right? So important to say that was a post hoc analysis and it was a non-inferiority trial. It was limited, remember, again, to higher risk patients. So this is very specific to a certain patient population. So I think these outcomes are very encouraging. I'm incredibly enthusiastic about these things. There was notably higher GI side effects in tirzepatide compared to dulaglutide, and that's notable. There was also a higher discontinuation rate slightly with tirzepatide than there was with dulaglutide, which should not cause anyone to say, I'm not going to prescribe that medication. Again, I think that the multiple mechanisms to get to this outcome is actually really important. And I think we should be looking at other drugs that have dual mechanisms so that we can actually have more effect in the long term. There are many more drugs, I think, coming out. And there's many more drugs also that are not going to be subcutaneous. Some oral medications that are coming out that have been known to be subcutaneous. So this is going to keep evolving. Anybody who is listening right now, really keep your ear to the ground on this one, because this is going to be something that continues to evolve every single meeting, every single year for us and for our patients to learn from.
Absolutely. Okay. Now let's talk about beta blockers. Over the past decade or so, several studies have looked at the question of whether all patients really need long-term beta blocker therapy after MI. The question is based on the fact that treatment for heart attacks has really evolved since beta blockers were originally studied for this. And more recent studies have sliced and diced the question in various ways, and the results have been mixed. This study looked at discontinuation of beta blockers a year after MI in patients without left ventricular systolic dysfunction or heart failure who were in stable condition. What was learned, and how does this add to the body of evidence around this question?
This was a fascinating one. I was actually in the room when it was being presented, and I think everybody was really hanging on the next words of the team, kind of thinking about man, can I discontinue some of my medications? All of us know that our patients hate taking all of these medications. Which ones would be safe for me to stop eventually? And as you were mentioning, there have been numerous trials that beta blocker use started initially after an MI may not be as beneficial or necessary. But this is a really interesting trial in that all of these patients were on a beta blocker for at least a year prior to it being discontinued, which I think is an important thing for everybody to recognize, that this is down the line. And for me as a cardiologist, thinking about when I can stop a dual antiplatelet therapy, those sorts of things, it's around that 1 year anniversary that I maybe can start thinking about stopping a beta blocker. And what they found was a primary endpoint for death from any cause, recurrent MI, heart failure, hospitalization, and that those who stopped their beta blocker was found to have a non-inferiority outcome. So this is important in that we can potentially decrease the amount of medications that our patients are taking. Notably, what they did, I would say that some of the EFs were actually not normal per se. It was greater than or equal to 40% and no evidence of clinical heart failure. And that was the patient population that they really allowed to potentially consider continue beta blocker versus not continue beta blocker. One of the issues that I had with this is that there are only about 12.8% women in this study alone, which is really important for us to remember that maybe this is not as broadly applicable to women, but also this was a study that was only done in South Korea. And the authors really did acknowledge that we would have to think about its applicability broadly. In America, in some of the United States, we use other beta blockers. The majority of the beta blockers that were stopped in this trial were carvedilol, bisoprolol, and nebivolol. And we use carvedilol, I think, pretty regularly, but maybe not as much those other medications. And I think I personally see a lot of people on metoprolol. So, we would have to think if this would be something that you could trial or apply directly to the patients here. But I think that this is a really great start for us to say, in the setting where we have all of these other outstanding medications, what we know have huge impact, maybe we don't need this one anymore. Or maybe we only need it for the year, which would be the takeaway from this exact study.
Okay. I want to switch gears a little bit to talk about a study in patients with long COVID.
Yeah.
New data were presented from the U.S. National Institutes of Health funded RECOVER research program on long COVID. The RECOVER autonomic trial investigated treatment for POTS, or postural orthostatic tachycardia syndrome, in the post-COVID setting. According to the researchers, POTS occurs in a third of people with long COVID. They studied whether the heart failure drug ivabradine would improve orthostatic intolerance, quality of life, and heart rate in long COVID POTS. So what did they find?
So this study was one that I was like, man, I will apply this on, Thursday morning when I am back in clinic, because I see a lot of these patients in my office and my heart goes out to these patients because really their quality of life and the limitations that they have from the symptoms of POTS is incredibly disabling. And this is a study that was really looked at only post-COVID POTS. So again, really, there's a lot of patients who have POTS, but this is very specifically POTS from COVID. And the primary endpoint here, importantly, was actually the change in the orthostatic hypotension questionnaire score, which is the validated score that they used. And the secondary endpoint was a change in heart rate after the initiation. And for us to keep in mind, and those who don't use ivabradine frequently as others, ivabradine really works typically by lowering heart rates. And so importantly, they had to include patients. One of the inclusion criteria was that patients had to have more than a 30 beats per minute increase with standing in order to really even be included in this. And interestingly, they looked at ivabradine versus placebo, but they also looked at ivabradine with usual care versus ivabradine with coordinated care, which for me as a person who's been treating POTS for a very long time, that coordinated care really is important as we think about all of the other things for treatment of POTS for autonomic dysregulation, such as abdominal binders, such as physical reconditioning, such as hydration and high salt intake. Those things are actually just as important, in my opinion, to treat this disorder as it is to maybe have a a medication in our back pocket. And what they saw is that ivabradine actually did not change the orthostatic hypotension questionnaire numbers exactly. That said, we did see some benefit with the coordinated care with the ivabradine. And we did see that ivabradine lowered heart rates. So in general, it was a little bit of a mixed outcome here. Ivabradine's not going to be your go-to like magic wand that I can give to these patients. That said, it weighs a lot on the coordinated care, which I think is really important. And it raises the possibility of maybe there's a subset of this exact group of patient population that would actually benefit from ivabradine alone, but it wasn't writ large across the entire study.
Okay. Finally, I'd love to end on a little conversation about the shingles vaccine. There's been growing evidence of a protective association of the shingles vaccine on cardiovascular disease and dementia. A new large observational study examined that association in people with existing heart disease. It looked at cardiovascular outcomes in about 250,000 US adults, about half of whom had received at least one dose of a shingles vaccine. Tell us about this.
Yeah, this is also fascinating and I think deserves the limelight as you appropriately picked this one to discuss. Again, retrospective observational, as you said, so association and not causation, and we have to be careful about that. And interestingly, they looked at MACE in the 1 month to 1 year, right? So we don't have long-term outcomes. This is a relatively short. But what they found was that the vaccine was associated with lower amounts of MACE, which included all-cause mortality and stroke and incident MI. And also, interestingly, that the vaccine was associated with lower rates of venous thromboembolism, heart failure, and atrial fibrillation and atrial flutter, which makes, to me, a lot of sense. Like this vaccine, what we think, and the measurement is really hard, but what we think we know vaccines do is decrease infection by virus, which we know increases inflammation. And so this then is a longer term outcome of protecting ourselves from those things up front. I do think it's important to recognize that there is some bias here in the sense that it is observational and that measuring something in a behavior of patients who go get a vaccine versus patients who do not self-choose to go get a vaccine, there's possibly a change also in the way that those patients live their lives, the other choices that they make, the places that they live, those sorts of things. It presumes a fair amount of access to vaccines and whatnot and socioeconomic status. And so I think it's important to think about that, but this really should be hypothesis generating and really there's no harm in getting the vaccine and actually great potential benefit for us to get a shingles vaccine, especially in this age population and the higher risk, right? This is, again, patients that had known ASCVD and should absolutely be something that both our primary care physicians and providers, but also our cardiologists are talking about the utility of vaccines and how that can benefit cardiovascular health in addition to decreasing shingles complications.
Right. So you were referring to what's called the healthy vaccinee bias.
Yes.
The idea that people who receive vaccines may have healthier behaviors overall than people who don't, which could influence the findings in an observational study like this. And in this study, the researchers controlled for some of those behaviors as well as some socioeconomic factors. But they also pointed out that the very large sample size, as I mentioned, it was around 250,000 people, and the statistical methodology they used in the analysis support what they call a high degree of confidence that the vaccine itself is playing a protective role.
Absolutely. Yes, I trust this exactly. I mean, that's 250,000 patients that you got right there. And I think the effect was significant. It's not borderline. This was a significant decrease in that patient population. It did represent both men and women. It was about 60% male. It was a little bit more white, 75% white in our patient population. While they tried to control for that, I think we should think about those things and its application across all races and ethnicities, but a really important finding. And I think, again, highlights the importance of the many things that we can do to improve our cardiovascular health, which are not just the direct, what we think of as blood pressure or cholesterol. Those are obvious things that we think about, I think, nowadays for cardiovascular health. But the things that surround it and really layer into our cardiovascular health are things like vaccinations.
Thank you so much, Dr. Berlacher. It's been such a pleasure chatting with you.
Likewise, Jen. Thanks for having me.
That's it for this episode of JAMA Medical News. Thanks to Dr. Katie Berlacher for joining me. I'm Jennifer Abbasi. This episode was produced by Daniel Lassisi at the JAMA Network. You can find all of our news stories at jamamedicalnews.com. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.